It is now my honor to introduce our next speaker. We just heard all about LDL, but how low can you go? And that is the topic that Professor Gabriel Steg, who's chief of the Department of Cardiology at Hôpital Bichat, and the vice president in charge of research of the Board of Assistance Publique Hospital de Paris, a network since 2018, but most importantly, a very, very close friend, leader of multitudes of large-scale clinical trials, including Odyssey. He will talk to us about how low can we go. Dr. Steg.
Hello, it's an honor to be here, and it's challenging to speak after Dr. Sabatine, especially as I'm going to largely paraphrase what he just presented, as you'll see. So I'll be quick. These are my disclosures. I've been working with lipid-lowering companies, in particular, Sanofi and Regeneron for the Odyssey Outcomes trial. So first of all, the first point I'd like to make is when we treat our patients with modern drugs, we sometimes get very low LDL cholesterol values, but sometimes these values are not genuine. And we know they're based often on the free world equation, which cannot be totally accurate, particularly if there are elevated TGs. And sometimes patients report values that are in the teens, even some labs report negative values, and these are related to calculations rather than direct measurements. And when you compare directly measured LDL cholesterol levels to the Fridwell calculated cholesterol levels, there can be some substantial differences. So I think it's important to remember that what we're seeing are often estimates of LDL cholesterol rather than measures of LDL cholesterol. Now, that being said, how low can we go? Well, we have evidence that lower is better, and we have evidence from randomized controlled trials, prospective cohort studies, and Mendelian randomization studies that there is a direct linear relationship between the magnitude of exposure to LDL cholesterol and the proportional reduction in the risk of coronary heart disease. And there is no inflection in those lines. As you can see, they're linear up to 0, suggesting that 0 is almost the ideal goal. And as was presented again earlier, we have evidence from populations that are chronically exposed to very low levels of cholesterol lifelong that they're virtually immune to atherosclerosis, even though they may sometimes have a high level of systemic inflammation, such as the Tsimane population of the Amazon, who have chronic helminthic infections, therefore high CRP, but low LDL cholesterol, and are almost completely immune to atherosclerosis. In addition, we have strong evidence of safety and efficacy from trials, in particular the PCSK9 trials, and both in the Fourier trial and the Odyssey Outcomes trial, when you looked at achieved LDL cholesterol levels and the extent of mortality or cardiovascular events, lower was clearly better, at least down to very low values. There becomes a point here where the confidence intervals are quite wide because we didn't have that many patients in very low values in Odyssey, but in Fourier, there were more patients at very low values related to design issues between the two trials, and really there's no inflection in those curves. And that was also seen in large observational studies. Lower was better in large observational studies such as this Sweetheart registry analysis of, quote, real-world outcomes. Patients receiving earlier and more intensive statin therapy derived greater benefit. Now, sometimes people criticize the trials saying, well, they're short duration. Well, luckily, the Fourier investigators extended their observations with the open label extension of Fourier. And they recently published in Circulation the fact that lower achieved LDL cholesterol levels were associated with lower event rates, down to LDL cholesterol levels below 20 milligrams per deciliter. You can see here in red, that is the group of patients who achieved LDL cholesterol levels below 20. And it's very clear that they have the lowest event rates. There's a graded relationship between LDL cholesterol achieved in a Fourier open label extension and the event rates. Now, how safe is that? Well, this complicated table makes the same point that Dr. Sabatine made earlier. There's no hint of increased safety signals as cholesterol gets lower, but I think this slide is quite striking. This slide compares the subset of patients who achieved an LDL cholesterol of less than 10 in red, and those who achieved an LDL cholesterol of more than 100 in blue. And as you can see, there's a dramatic difference in cardiovascular outcomes, so efficacy, but no hint of increased safety issues. Now, let's examine specific safety concerns. And Dr. Sabatine will remember that when we embarked on these trials more than 10 years ago, people predicted havoc would happen to the trials in our patients, that they would have depression, cognition problems, diabetes, cancer, you name it. So we've looked at all of these issues. Cognition, there was actually a cognition sub-study of Fourier that found no signal of cognition problem in that study. But I will grant you that this is a relatively young patient population, and maybe the follow-up was relatively brief. Now, what about the overall trial population in Fourier? Was there any difference in cognitive decline over the duration of the study in the overall trial? No hint. Or in patients who achieved an LDL cholesterol of less than 20 compared to those who achieved an LDL cholesterol above 100? No hint of a signal. Any problems with intracranial hemorrhage? There's a rumor from stroke trials that there might be issues with low cholesterol and increased intracranial hemorrhage. Well, for instance, in Odyssey outcomes, the rate of hemorrhagic stroke was actually numerically lower with alirocumab than with placebo, despite a dramatic difference in LDL cholesterol. And in addition, if I can go back, whoops. And in addition, there was no relationship between low on-treatment LDL cholesterol and the incidence of hemorrhagic stroke in the alirocumab arm. What about cataracts? Well, we are publishing in the next couple of weeks a paper in an ophthalmology journal showing that there's no increased incidence of cataracts in the alirocumab arm compared to the placebo arm, neither in the overall trial patient population, nor in patients who achieved consistent levels of LDL cholesterol below 25 or even below 15. What about new onset diabetes? Well, again, we looked at this very carefully in both the Fourier and the Odyssey outcomes trial. Here are the Odyssey results. The HbA1c levels were, if anything, lower in alirocumab-treated patients than in placebo patients. The fasting glucose levels were identical. And the rate of new onset diabetes that we looked at with a myriad definitions, different definitions, using all sorts of sensitivity analyses, the hazard ratio is 1.00. No increased risk of diabetes with PCSK9 inhibitors. So if you summarize the safety, these are remarkable agents. They're very well tolerated. They get LDL cholesterol to very low levels, and there's no hint of a safety issue other than local injection site reactions, which generally are mild, self-limited, and tend to occur early during treatment. In addition, we have evidence from many studies, and I will quote only one, that achieving very low LDL cholesterol levels will result in both quantitative and qualitative changes in plaque and really take us towards plaque regression. And I think that's important to know, but it's also important to mention in our conversation with patients to emphasize and insist on adherence to treatment. It's really worthwhile not only to achieve goals, but to get cholesterol as low as possible with well-tolerated agents, because if you get cholesterol to very low levels, then you're able to achieve plaque regression and plaque stabilization. And a good example of this, it's one of many studies, is the recent Pac-Man AMI trial, in which AMI patients underwent treatment, randomized allocation to either alirocumab or placebo early on, and then detailed intravascular imaging. And as you know, there was a dramatic difference in the LDL cholesterol levels, 75 in the placebo arm, 24 in the treatment arm, and that translated in changes in atheroma volume, so plaque volume, but also changes in the plaque composition that suggest that the plaque is less vulnerable to rupture and less prone to leading to subsequent events. So both qualitative and quantitative changes that are really reassuring. So my conclusion is very simple. There is no such thing as too low an LDL cholesterol level. And the one thing to do if a patient shows you an extremely low LDL cholesterol level is congratulate that patient.